So he is known for his groundbreaking work, unwavering dedication and commitment towards orthopedics, especially in Telangana and India. So Professor Paravastu Rangachary sir, born in 1927, Dr. Rangachary finished his schooling in Vijayanagaram and came to Visakhapatnam for his BSc in 1948. Initially, he was interested to become a pilot and he was forced to apply for an MBBS seat in the combined Madras state by his cousin, noted scientist Dr. Samavedam Sriramachari, a former director ICMR and founder director of Institute of Pathology ICMR, who investigated Bhopal gas tragedy. He completed his MBBS in 1953 from Andhra Medical College, Visakhapatnam. Rangachary garu used to tell everyone how he was trained in MBBS by able gurus who taught many precise clinical skills that helped him master. In those days, it would take months to get an X-ray done, and so they were taught how to examine and rectify at the earliest. He also worked in the Department of Gynecology initially and started his government service where he went village to village to treat patients. When cholera was much prevalent, he learned how to treat by giving drip with pure coconut water in remote villages. Having a great passion towards engineering, he chose orthopedics under the able guidance of Professor Dr.P.Rangachary garu and completed it in year 1962 with gold medal. Under his guidance, he learned so many techniques and art of close reduction. He had a wonderful art of putting gypsona plaster in a very classic way, as told by his students who are teachers to most of us here. Dr. Rangachary garu assisted Dr. Rangachary garu in many difficult and complicated polio deformity corrections and helped to publish papers. Photography was one of his favorite hobby, which helped him to take photos and prepare slides for paper presentations and teaching. He started his teaching profession in Rangaraya Medical College as a lecturer and head of the department. He was indeed a very good teacher and explains the subject from the basics with good drawings and photographs, drawing 100% attendance in his classes. In the year 1967, Dr. Rangachary garu working in Kakinada applied for FRACS under Colombo plan and went to Melbourne, Australia. He worked along with Dr. Henry Vermont Kroc on vascular supply of bones of hand and wrist. In the second half of 1977, he went to Melbourne, Australia again to do research work on venous drainage of upper end of femur and also got trained in spinal surgery. His work along with Dr. H.V. Kroc and their research paper in the form of a book is placed in Royal Albert Hall, London. As he returned to India, he worked at Andhra Medical College and Usmania Medical College, where he trained many postgraduates. He continued as Professor Emeritus at OMC post-retirement. The best part of all the doctors who worked under him was that they always got motivated to try new techniques and methods and stood by him at all times and presented them in various national platforms. He published more than 35 papers in international and national journals. He was also elected as fellow at FAMS in 1968, FAASC in 1970, and FASI in 1989. In the year 1981, took voluntary retirement from AP government and went to Jamaica as he was invited to set up an orthopedic department there in Montego Bay. In 1986, as he returned to Hyderabad, he joined Deccan Medical College until 2002 as head of the department, where he continued to inspire many students and treat complex cases. He continued to practice until 2018, treating and training many students. In 2018, Dr. Rangachary garu totally stopped practice and was actively involved in writing book on management of different type of fractures along with self-drawn drawings. So now I request one of the disciples of Professor Paravastu Rangachary sir, our beloved V.S. Ravindranath sir, to come on stage to give an oration on his name. So with great honor and pride, I would like to introduce Professor Dr. V.S. Ravindranath sir, who is teacher in my post-graduation days. And Professor Dr. V.S. Ravindranath sir has done MBBS from Osmania University, MS Orthopedics from NTR University of Health Sciences, Professor of Orthopedics in Osmania Medical College, Osmania General Hospital, Hyderabad. And present place of work is Professor and Head of the Department at ESIC Medical College, Hyderabad. Teaching experience of 31 years as Assistant Professor, Associate Professor and Professor in Osmania Medical College, Osmania General Hospital, Hyderabad, Telangana, ESIC Medical College, Sanat Nagar, Hyderabad, Telangana, Bhaskara Medical College, Joginpalli, RR District, Telangana. Publications, 16 publications, both national and international journals. Designed a new device for tibial plateau fractures, published in JOCR journal, gold medal award paper in last conference, and designed a device for the entry point into greater trochanter for any IM fixation of femur, published in IOSR journal, gold medal awarded paper, radiolucent bolster for different orthopedic procedures, and project work is going on presently for innovation fixation of bimalleolar fractures of ankles. Academic activities, he has conducted and conducting national level Elizaro workshops, DNB and postgraduate student seminars, CME, mock examinations and postgraduate clinics. Examiner for DNB students, regularly taking classes for postgraduate students in Osmania General Hospital and ESIC Medical College till date. Presented more than 55 scientific papers in national and regional conferences. So he is again known as teachers to teachers, and most of the DNB students in Hyderabad are regularly they have attended his teachings before giving their DNB examination. Sir, I request you to kindly deliver Professor Paravastu Rangachary sir oration. Over to you, sir.
Good morning, all of you. At the outset, I wish to thank the TOSA and TOSACON team, headed by Professor Timmareddy and Srinivas Kasha, Chandrasekhar and Raju Iyengar, for giving this opportunity for me to deliver one of my beloved teacher, Parvastu Rangachary sir. I am Dr. Ravindranath, standing before you. As a person, he's a legendary person, and he's got a unique personality as a teacher and as a surgeon. Patient equivalent to earth. He has got that much of patience. When he's examining the patient, it takes long time, and to write the prescription, that much long time, and explaining them what to do in his prescription. He has got tenacity to surgical practice, so much so he can withstand or stand for hours together, even at the age of 93. When somebody is doing surgery, he used to stand beside him, advising him how to do it. And he has got some unique concepts about vascular supply of the patella as well as scaphoid. And he is very much known for a typical 3 tourniquet technique, which he used to apply for repair of the extensor mechanism following petelectomy, where the tourniquet can be there for more than 3 hours. And I have operated on his relation when he was a 91-year-old. The surgery went on for about 3.5 hours, along with my colleague, Dr. R.K. Reddy. He never used to sit down in the change room. He used to sit in a tripod stool all through the 3.5 hours at the age of 90 years. And at the age of 92 years, he has operated on the wrist joint of one of my own classmates for some lower end of the radius fracture. And fortunately or unfortunately, I had to operate him on his 93rd year for a fractured femur, neck of the femur with bipolar arthroplasty. And he died of COVID consequences. And as Watson Jones says, life should not go through pelvis. That's very crucial. The suffering is terrible when life goes through pelvis. I recently came to know about one small incident about Rangachary sir. A thief is brought to him with a handcuffed from behind the buttocks. When he was trying to wiggle out to escape from the police, the patient developed bilateral unit dislocation. And the observation by the Rangachary sir is that it got dislocated because of the forceful pronation either by the patient or by the police people. And he has reduced it in the emergency room, reversing the mechanism of dislocation, a simple supination of the forearm. Both units have got relocated back. This is all about his personal idiosyncrasies, or what we can say. He was associated with one person by name Henry V. Koch, and you can see both of them are twins. And he worked with Koch, who has written a book on vascular supply of all bones, more particularly the head of the femur, that is known everybody as Koch's hypothesis, along with Toito hypothesis. And there is a book, that is what somebody was mentioning, it's there in the annals of the British libraries. And that book was given as a complimentary to Rangachary sir when he visited Australia. I used to see them always carrying all these gadgets, the camera. Those days, they used to have only black and white film cameras. And he's very much fond of writing tons of papers together before the invention of this typewriter. And then he used to produce, when he was in Jamaica after his retirement from AP service, he used to take some beautiful black and white photographs. You can excel in photograph only by black and white films only. It's very difficult to get excellence in black and white photography. These are one of the photographs. And you can see the life in the face of that particular girl, and also young adult. This is the prescription. Many think it is very a waste of time. This is what we should expect to write and explain to the patient. And during his process of his career, he has done about almost more than 350 anti-spinal fusion in a primitive setups. No high-tech technology, no high-tech OT operation theaters, in a very primitive setups. And it's very rare to see such prescription nowadays. Professor Rangachary sir was associated with one of the two stalwarts, like ASO sir and Vijay Raghavan sir. And I had the opportunity to work with them for about 4 months continuously during 1999 conference, All India conference. And it's a great feeling, you know, what happens when you work with them, I'll tell you. And there's one more personality unknown to many of us, Professor V.R.K. Sastry. You spend some time with them, every time you find some point or other which attracts you in your practice of medicine. And is there any commonality between these two people? The gray hair. And he has, when he retired from service, he has donated some instruments and books to the present medical college. And this video should really melt every heart. He's a Bain person. And you see his accuracy in getting target. And you see person who is helping him to reach his unloading into the truck there. And when he walks back, you see how accurate he used to reach that particular basket. That really melts every heart. We should not keep on complaining that we don't have these facilities, we don't have those facilities. And attitude matters a lot. Attitude is the only rule of any person to develop or disintegrate. Attitude is very important. Spending some time with these people, you feel that teaching is a passion and is never by a designation. We spend some time with those people and you feel that teaching is always a passion, not by a designation. And my feeling about things, I always feel that make things simple. Even if it's complicated surgery also, try to make it very simple as possible. And I always feel I have an optimistic attitude to say that when I can do it, everybody can easily do it. It's very simple. And I don't believe that I will always promise moons to the patient or moons to the two students also. That should be that's what I have, that's my attitude here. And this is very crucial for me. I never miss a chance. Whether it's a teaching program or a practical, a typical or complicated surgery, you should never miss a chance to do either teaching or a surgical procedure. And we should not complain that there is not much crowd, like there is only one PG, I can't teach him. For a simple reason that Bhagavad Gita or Bhagavatam are not taught to multiple peoples. They are only taught to single individuals. So let us not complain that no student is there like that. And my perspective as a teacher is discipline is very crucial. No discipline, nothing of that sort. And demonstration of clinical science is very crucial here. And then discipline in the operation theatre is very crucial. And you should have a little lateral thinking when you can deviate a little away from it and how to get the best of the patient while in theatre. At the end of the day, life is not just orthopedics. And this is my classroom in my demonstration room. My students will always come like this. There is no compromise. If they don't come in white aprons, they have to go back home and come next day morning. Even girls, I insist them to come in shoes. No fancy dresses, no fancy footwear also. I don't believe we should have woke liberalization in students. That's not there, fortunately, in Indian circumstances. The reason is we should have a pleasant presentation to the patient, and patient should feel that this particular doctor is going to help me or alleviate me my symptoms or pain. That should be there in the minds of the patient when he looks at a postgraduate or a consultant. Punctuality is very crucial. There is no compromise in the punctuality again. And when we have we take advantage of this technology, even in emergency room, there's nothing like shortcuts while you're writing the case sheets. That should be there with the student when you're writing the case sheets. And you see that the case sheet is very complete with a nice diagnosis. And then when you see when we take the help of the WhatsApp images, we formed 3 groups. One is all admissions in one group, and we have one more group, only pre-operative plan, and the other one is the post-operative plan. So when we go through these WhatsApp groups, we'll know everything about a particular case, pre-operative, post-operative, and follow-up. And you also realize that when you take a radiograph in the casualty, we should never miss a chance to take the relevant chest X-rays in the form of traction views and try to get the classification immediately so that the student will not miss the classification in future. And demonstration of clinical science is very crucial. And we take the help of acrylic models. When you want to discuss about squaring of the pelvis, this is more confusing to the students in the examination. And here, we have a small video wherein the acrylic model is created by me, and we have the 3 joints there at lumbosacral junction and one at both hip joints. And this explains how these nuts we tighten the nuts at the lumbosacral junction. There is supple junction at the lumbosacral spine. And both hip joints, when you tighten them, you can tighten them in adduction position or an abduction position. And what happens when you move the pelvis with a free or supple lumbosacral junction? For example, this adduction deformity, when you tighten the screw there, the hip is fixed in adduction, and the other hip is normal, which is very free, and the lumbosacral junction is normal. When you try to rotate both limbs to reach parallel to each other so that the patient can propel forwards, you realize that the anterior spine on the adductor side is elevated. When you want to do a squaring of the pelvis, there's a lot of confusion among students. Why we get equal levels of the that's gone there. Where we get equal levels, we can demonstrate by keeping them parallel to each other. That's not coming out. When you bring them together so that we can keep the diseased limb in abnormal position, both anterior spine are the same level and take the real measurements. This particular model is going to help a lot of people in the examination also. And when you want to do some better way of demonstration of, let us say, the anterior droid test. So this is the normal, no anti-droid test here. There is no tear in the ACL. If you can take a dissection there and then join them, both of them together, you realize that you're doing a good demonstration of the ACL tear. But if there is a tear, you can easily take the help of this amputated limb and dissect it out and do the same test on the table, and you realize that how important it is, how easy to demonstrate the ACL tear in a sagittal plane when there are no rotary instabilities. So never try away amputated limb. Try to dissect as much whenever you have a chance. And this particular sign, most of the spine surgeons may not be aware. This is very crucial. We rarely get to see them. This is called, there is a sudden withdrawal of the lower limbs when you try to tap on any part of the lower limb when there is spastic paraplegia. This is called a Moss sign or Moss reflex. It has a prognostic value. The presence of this sign indicates that you are not able to decompress the spine properly, and patient continues to have the paraplegia. And we have a small template for radiographs, how to read a radiograph for students in a bone lesion. It starts with views, very crucial to know the views, and then the age of the skeleton, immature or mature, and soft tissue swelling. And for that, when I go through some radiological textbooks, we have an experiment where we put a dry cotton in front of a flashlight to get a silhouette effect, and wet cotton when you in front of the flash of light. You realize that there is a change in the density of the cotton. The same thing happens when there is a soft tissue shadow in a plain radiograph. And you know the location of the anatomy location of that particular area. You can make a diagnosis of a semi-membranous cyst, and which can be confirmed by your dissection and histopathological examination. And continuing the template again, we have the template is gold standard for reading a plain radiograph and specific for some lesions. For example, you have a lesion in the epiphysis, and then which is eccentric in nature, in immature skeleton, invariably it's going to be an chondroblastoma. You can confirm it by your investigative modalities like MRI, but most of the time they are all, 99% of the time they're all chondroblastomas if they are epiphyseal and eccentric in a mature skeleton. And you realize that most of the lesions are all in the metaphysis, and then they're all specified to the particular location in the metaphysis. And the periosteal change is very crucial to make a diagnosis, more so in a conventional osteosarcoma or in a Ewing sarcoma. Cortical changes are not going to much help when you want to make a diagnosis, but the matrix is going to help. That's called, it's a ground glass appearance, like when you can make a diagnosis of a fibrous dysplasia. And the classification of Ludlows is very crucial to confirm your diagnosis on a plain radiograph. And then the zone of transition is very important, to know whether it's a benign lesion or a malignant lesion, which is distinct or indistinct nature. And this template has been used by me for almost more than two decades during home series, and it's going to be useful for students when you want to make a diagnosis reading plain radiograph alone. What happens when you don't follow this template? This is a fracture of the lower part of the femur, and in both views. Very crucial is there is a history of trauma. There is a history of trauma. We should elicit whether the trauma is significant or not, and then you can take a. You should see for this periosteal reaction here. This is very crucial, and if you don't follow the periosteal reaction there, and don't follow the Lodwig's classification, and then zone of transition very clearly, and this is what happens. An immature person will put a K-wire inside, and then he'll come with a picture like that after 2 months' time, and where you make a diagnosis which is very wrong, and so is the treatment. And at the end of the day, it's a blown-up lesion with a lot of contamination in different compartments. Can we make a diagnosis on a plain radiograph in case of a port spine? Or what type of lesion is going to be there in a port spine and a plain radiograph? For example, this is a minimal wedging at D9 level with a lot of regional osteoporosis. Can we really make a diagnosis of a cold abscess on a plain radiograph? Here is a trick for that. There is a shadow there, and then you can see a shadow there. Within the hot shadow, you can see a nice shadow. Dr.Rangachary sir used to say that he used to use words like container and contents. When you have a container which is thinner in nature, you can see what inside the container contains like thin wall, as vertebral laminae, pedicles are all clearly visible. That means there's a thin wall psoas abscess that you can confirm by your MRI. And then when you open it up, you find an abscess there, and you decompress it, the patient recovers from this neurological deficit. So a simple plain radiograph can easily give you a diagnosis of an early onset of paraplegia and the size or nature of the cold abscess. Suppose if the abscess is for longer duration, the container and contents will behave differently. There's a thick wall, and you don't see the contents within the container, and that's going to be a thick wall abscess, and the neurological recovery is not much as we expect in thin wall. These particular videos are very crucial to know which hip joint is at fault and why is at fault. Because the patient is using stick on the same side and the patient is using stick on the opposite side. A teacher should be able to explain what is happening to joint reaction and in correspond to abduction force. So somebody is using a stick on the same side and he feels comfortable. It's an unstable joint. He uses stick on the opposite side. It is a degenerative joint where he has to bring down the amount of abduction force to bring down the pain. So if you see a radiograph like that, it's on the right side, the pathology. And then when you do the surgery, a patient gets relieved of the pain. And follow the same template when you want to read a joint, radiograph of a joint. This is how I advise the students to follow it. On the femoral side first, on the acetabular side next, and joint space, and make a diagnosis. In the femoral side again, you have to think of what are changes in the head, neck, and the trochanteric area, and what are the changes in the acetabulum, the size, shape, index, and inclination, and what is happening to joint space. The joint space is very crucial. Is it eccentric narrowing or a concentric narrowing? 99% of the tuberculous hip joints, they have a concentric narrowing, whereas other cases like Perthes disease, they have eccentric narrowing of joint space, though it's incongruous. So this template is very crucial to read a joint lesion. Then you can make an easy diagnosis. Suppose there is a small case, a person comes with this gait using crutches since his childhood. The resident did not use the word, did not put a question, how long you are using these crutches. So use of crutches is very crucial because he's so comfortable using crutches, but he comes with the trivial trauma and with this radiograph. You make a diagnosis, diagnosis is very simple. It's a fractured femur, and then there's a dislocation of the hip joint. Now, if you take a pelvis with both hip joints, and that's the picture. It is not so simple why a person can come with a dislocation as well as fracture to the shaft of the femur comfortably using a crane, using the auxiliary crutches. So this is one place where even for the first time I am able to appreciate the vascular sign of Narath here, because the head is outside the socket, but there is no pain, and patient is has no tenderness also. It should give a clue that we should have priorities how to treat this particular patient. So putting the hands on the patient is very crucial. When you see on his back, there's a big lesion, a myelocele in the upper part of the lumbar spine. That produces a sort of monoparesis or monoplegia where he has no pain. Patient is walking on the forefoot, on the dorsum of the forefoot since his childhood. And again, you have the same joint, the template for the joint, and follow the same template like femoral side, acetabular side, and joint space. And then you try to prioritize your treatment. Whether you want to treat only fracture, or you want to treat both fracture and dislocation, or only dislocation at a later time. But one thing is very crucial here. Once you see this particular picture, I feel I as a teacher insist that you should not be in a hurry to do anything to the hip joint. There's infected, non-healing ulcers over his forefoot since as per him, about 20 years. So you should think that twice or thrice before you do anything onto the hip joint. And this is the picture. Yesterday, 2 days before, we have done this surgery. We have just fixed the femur. If he's comfortable with that, let us not touch the hip joint. That should be a teaching for the students, youngsters, instead of jumping onto the hip joint and then doing some replacement or a relocation of it. A senior person should always be involved in practice of conservative management of fracture disease. Here, my stress is on thumb traction when you want to reduce a Colles fracture. We always use the reduction, counter traction using only 2 metacarpals. That the answer should be, a teacher should be able to explain why we are not using the whole of the palm. We are using only two fingers, either index or middle finger or little ring finger. That is to avoid crowding of the metacarpals. And then it's always essential to interact with the patients. And this particular fracture clinic is very crucial. It should be there in every orthopedic department, both in inpatient as well as an outpatient. That is the area where the faculty will interact with the post-graduation and then exchange the views, or they can learn things better in the fracture clinic. And this particular video, very crucial. And we'll think that this is nothing but a Trendelenburg sign. You can easily appreciate that. There's no problem in identifying it's a Trendelenburg sign, but you look at this video, and that is classical Trendelenburg sign. Then how did you get this particular image on the left side? He has got a non-union of the subtrochanteric fracture. Any fracture, it goes into non-union, proximal to the isthmus and distal to the lesser trochanter. You have such a clinical scenario where it looks like unstable hip joint, but it's not a classical Trendelenburg sign. But other one is a dislocated or a DDH in the child. So appreciation of this particular telescopic sign by the examiner, explaining them to the student is very crucial when you don't want to make a mistake. And the other test is telescopic test. You should know where to put your fingers first, and where to hold the arm in the metaphysis of the femur, And then what is the first movement that you want to do while you want to use a telescopy? This is very crucial when you want to do a telescopy. Telescopy test is very crucial to make a clear diagnosis of unstable or stable hip joint. This is all about discipline in the clinical science. Now let's go to discipline in the operation theater. So there are so many lines like that. There are plenty of lines. You get just confused. And you make, as I said, you make things very simple. Follow a template like this. You take it on a A2 paper or a drawing paper or a photographic paper and cut the proximal part, producing a varus osteotomy, varus derotation osteotomy, and realize that the hip is relocated into the hip, but not the knee joint. Knee joint is still in valgus. So what to do? You should not get worried. Then you go to try to do one more cut in the supracondylar area of the femur, and the limb is straight, but still the hip is outside the socket. When you try to rotate, you realize that the limbs are parallel to each other. Head is relocated to the acetabulum, and there is a straight limb with a good mechanical axis. This is how you should make a template when you are planning for surgery for a deformity correction. As a senior surgeon, as a senior teacher, you should always get involved in the dissection, in the cadaveric dissections. This is from my colleague, Professor Dr.P.Rangachary. You should know how to do a surgical dissection in the cadavers. Whenever you get a chance, you should get involved in that. And design of the incision is very crucial. And we have the respectus tissues. Somebody wants to do surgery very fast. Yeah, you can do it very fast, provided you follow the surgical principles, try to respect the tissue planes, and then you can definitely do, there's nothing like doing surgery fast. You can do it in a reasonable time so that there will not be any bleeding when you follow the tissue planes. And you follow the tissue planes, you reach the target also very easily for better visualization of the fracture or a disease, whatever it is. So dissection in the cadavers is very crucial when you want to understand the different approaches around the joint. And this is, I'll go just a little faster. Whenever you want to do some ilizural procedure in the femur, the precise knowledge of anatomy is very crucial. You should have a three-dimensional view, what happens in the anterior, what happens in the posterior, what happens in the medial side, and what happens in the lateral side. This is how you can have a mental picture and to have an exact knowledge of the anatomy when you are trying to do fixation with the ilizural, putting pins in different planes in the femur. This is the vascular supply, and the venous return is there. You can see the venous return, and then you have the different anastomosis around the femur. They are called perforators, and around the trochanter, and you have the femoral nerve. You can see exact replication of the anatomy that is there in the human body. And the neurovascular structure on the posterior side, that's sciatic nerve. You should know the level of the branches occurring at sciatic nerve, the posterior tibial, anterior tibial, and now supply to different compartments of the posterior leg also. All these things are there when you have clear picture of anatomy three-dimensionally. So when you want to put the pins in that area, upper end, middle third, lower third, and then you can pass a reference wire without disturbing the neurovascular structures there. You should be able to interact with the students. What are the structures there? Ask them to name the muscles there. We should be able to explain them. At the end of the procedure, that particular muscle is popliteus. It is just behind the upper end of the tibia and very close to the vessels when it comes to the margin of the upper end of the tibia. So knowledge is very important, and you should interact with students with this type of presentation when you have chance to present it. And this is very crucial. Position of the patient. We have some bolsters like kidney trays, wooden blocks, and sandbags. But we have invented these particular bolsters which are lightweight in nature, non-deforming, and then they are radiolucent, 100% radiolucent, and then easy to manufacture also, easy to prepare also. And then you have stable limb position where you can use any position of the limb is very important. And these bolsters are all 100% radiolucent. And as a senior surgeon, I should not feel insulted why I should drape it. No, it's not like that. A draping should always be done or supervised by the senior most person. And for example, this is the draping for the arm, in the lateral position. That is the first layer. And you have the second layer, first layer going on the proximal part of it. And you have this second layer going in the distal, and then you receive the limb. Kindly kindly take attention while we are taking the limb, and this should be the ideal way of receiving the limb, so that it will not be any clumsiness when you hold the limb during the process. That is where you should drape it. That's what I feel. And somebody uses more than 6 drapes of 8x4, I consider to be is not a good surgeon to drape it. You should not use more than 6 drapes for any procedure, for any other hip, knee, or wherever it is. So whenever we are doing some procedures like a spastic lower limb child, we should be able to appreciate the clinical signs when you try to do a highly selective neurectomy. Suppose you want to bring down the amount of spasm of the gastrocnemius following the Skilford-Squall test. I want to bring down the spasm of only the middle head of the gastrocnemius. Appreciate the contraction of that. I only do the neurectomy of that particular area so that you get required amount of relaxation when you're doing a highly selective neurectomy. That is very much demonstrated here. So that's typical reaction of a tibialis posterior. We should be able to explain and demonstrate to the students so that you get impressed, the student gets impressed by your presentation. A little demonstration of this particular case. You can see deep grooves there. They are nothing but avulsion of the patellar tendon from the tibial tuberosity. The patella is much higher than the supracondylar area. You can bring it down by your skeletal traction and demonstrate that in due course of time, a period of, let us say, 3 weeks' time, the patella has come down to the level of its natural place, and then do reconstruction of the patellar tendon using a tensor fascia, making it as a tibial patellar tendon, fix it in different respective places, and then you get this. This is a dissection here, and this is a clinical outcome. You should be able to demonstrate the integrity of the quadriceps, asking the patient to climb the steps. That should be your demonstration to the students. Here there are no gadgets, no fiber wires, no anchors, all these things. A little lateral thinking is very crucial for a good teacher away from your routine one. And this is the design of appliance where you can keep the limb onto the that particular area, so that when you want to go for a posterior approach of the arm, it's a radiolucent one. There are no pressure over the chest wall, and you get more flexion when you have the design where you can see the lower part of the humerus very clearly when you get a more flexion. And this is one device which we developed in our college. And it has got outer sleeve. This is used for elevation of the depressed lateral condyle percutaneously using this procedure. And this is modified by, it was straight in shape, modified again with the curvature and when with graduations, so that you can you can reach the particular target, both anterior, middle, and posterior part of the condyles in the sagittal plane. These are the sequence events where we can move the depressed condyle and get the correction at the tibial plateau level and then fix with canthal screws. We have one more device where we have the entry point, and you can see the entry point has got some teeth. It goes and stucks onto the tendon of the gluteus medius. The great trochanter is not pierced. You can see the track of the great trochanter, the passing of the guide wire in both AP and lateral views without interfering the trochanter. Once you make a track in the trochanter, it's difficult to change the track so that you do not have to go into the trochanter. Before that only you can change the direction of the guide wire and then do a nice, very simple procedure called entry point for the upper end of the femur. Same thing can be used for lower part. You see the person is standing much away from your C-arm with this particular instrument so that you get a good lateral view. Once you get good lateral view, you get this type of fixation in the proximal femur, like in PFN, and that is the it's almost percutaneous procedure where you can get this, you can make use of this particular instrument. Sometimes in a clinical examination, patients will come with this particular MRI picture saying that they may diagnose a chondrosarcoma, but it's not like that. You should have some clinical suspicion, and then You take another view, you see this patient is aged about 15 years. Chondrosarcoma is very rare in 15 years. And you'll see very longer duration of the problem here. And then no periasteral changes. Chondrosarcoma will have some periasteral changes which are not present here. And then collapses is there on the posterior part of the lower part of the fragment. And it's nothing but a tuberculous osteomyelitis. Since it is an infection, we cannot put anything inside the body. And then we need to do some procedure outside the body in the form of Ilizero. And patient is comfortable with the anti-tuberculous therapy and then fixation, get a stable fixation, and that is the end of the day. So a diagnosis of a chondrosarcoma, it is said that for any oncological diagnosis, tuberculosis should be one of the differential diagnoses. But you should have some clinical suspicion based on age and duration, and then you can proceed further. And this is my interesting case for me, and not just orthopedics. A fellow comes like as an attender to his mother, and I just got hold of this boy, terrible grotesque appearance for him, post-Burns contracture, and as I said, draping is very crucial, and that is the release of the contracture and then grafting, and then you can see the boy and the movement of the such a nice fellow with a happy smile, and he can join society without any stigmas. Again, this boy has come as an attendant with his mother, hopping like that. When he's young, he can hop. When he becomes old, he cannot hop. So I just got hold of him and then used, theoretically, you can say I can correct the deformity by Ilizero, make it straight, but the limb is flail. It's not, there is no muscular action right from the hip joint to the ankle joint, and that is a terribly short limb. So my aim was to bring it straight so that we can give some appliances to him, correct deformity and make it straight. And then that is the double-decker HKFO. He's comfortable walking in that. You can adjust the height of the foot or double-decker as the child goes up and up. This is how, as a teacher, you should be able to impress the students that you can also do some vague procedures which are useful to the patient, not routine trauma or any other surgeries. And that's how he was walking. The question is, do all fractures need fixation? As a teacher, you should have a lot of confidence to withstand the peer pressure and retain the urge to put your knife on the patient. This patient has come in this particular radiograph. It looks very tempting, a beautiful fracture there, a long fracture extending from upper third to middle third. And the temptation is what type of plates you want to use, titanium or whatever it is, or what type of nails. A senior surgeon or teacher should be able to resist the temptation, and then just to see after 1 week time, the swelling has come down, and start doing a sort of rest for about 1 week in a J plaster, and then mobilize the patient with pendular exercises, and that's what happens after about 3 months' time. Do you think you can get better results with surgical procedure than this? Total abduction, pain-free. So humerus behaves humorously. So most of the time you can equally maintain that, treat that with conservative management. As a teacher, as I said, it's a rare community. Let us try to preserve it. And you should be able to pick up some rare cases looking at the literature. This is we do cross-leg flaps, but here we have taken the bone also along with the flap. A fibula is taken onto the other side of the limb for a hydrated cyst. We have removed the part of the tibia, and have taken bone as well as soft tissue. It's called osteofasciocutaneous flap. You should be able to do some vague procedures so that you can impress the students. And this is a case, a fellow of 24-year-old comes with us, comes dopey, with 1.5 years old intracapsular fracture. And pick up some rare procedures. This is, that is a muscle called sartorius muscle. And you cut it from the anterior iliac spine. Then it becomes a sartorius muscle pedicle. And then you fix it to the fracture area anteriorly. And that is a post-operative X-ray. If you do any rare procedures, you should be able to get And you could maintain the neck and neck shaft angle, and then that is the X-ray. The question is, how do you assess the vascularity of the head? I have a trick here, and you have the what you call anterior lip as well as posterior lip, and that is the area of the neck or head which is not overlapped by the anterior or posterior lip of the cerebellum. They are as lucent as the other side. That head is definitely vascular. The other one is head is congruous. 1 year old, if it's avascular, it goes into incongruous. So we have done that Sartor's muscle pedicle. If you expect good results, you're not going to be a good surgeon. So that is his preoperative gait, a 24-year-old fellow, and that is his postoperative gait. You should be able to get excellent results to impress upon the patient as well as the students. And I feel the lower end of the humerus is known as the graveyard of orthopedics. This is a case of a snake bite in childhood with a tethered skin all around. That means soft tissues are not as comfortable as we expect. This is, you can use the word like tibial kyphoscoliosis scoliosis. That means it's a round deformity. You can see that in X-ray. It's not angular deformity, it's a round deformity or semicircular deformity. So you can do correction by a simple Elizarov method and then get it corrected to a reasonable extent, and it becomes straight like that. As I said, do not promise moons to the patient. He is comfortable putting his foot on plantar grade and walking nicely. And the question is whether the alignment is stable or not. You can see it when he walks like that. You can see it very much stable. The knee is horizontal, the ankle is horizontal. The patient is comfortable with that. So don't expect to see a very great accurate reductions. If you get reasonably good reduction, good correction, you should be happy with the procedure. And you have one more case of 1 year old non-union. My favorite surgical procedure, this is. I always take the teaching is why should we take a lateral view, traction view as well as internal rotation. We should be able to explain why and when to take it and how much is the correction you want to do. As an orthoplastic surgeon, it looks very easy to replace it with the bipolar or total hip replacement. But much easier for everybody is to do a osteosynthesis procedure in the form of Meyer's muscle pedicle. And this happens to be my 79th case of muscle pedicle. And we have done the osteosynthesis. And again, we should be able to produce excellent results in this case. You see the graft is well incorporated there after 1 year follow-up. And you can see the patient is squatting well. This can never happen in replacement. And his gait is normal as before. So when you want to correct any ankle deformity, the stress is on, you should be able to see the correction from behind. When he's squatting down, the heel is much away from the ground or above the ground. When you do Elizarov fixation before correction, it's much away from the ground. And when you correct like that, it's equal to that. You should not be happy with that. You should make him squat again. The heel should touch the ground. The teaching is the heel should touch the ground, then only your correction is good. And then that's evident by your gait also, not from in front. You look from behind. That should be your gait following correction of the deformity. And as I said, life is not just orthopedics. I have some pencil sketches. They are there in Department of Orthopedics in Usmania. I enjoyed that sketching of about 17 stalwarts of orthopedics. Similarly, I have done the same procedure, same pencil sketches of 17 people in plastic surgery, all the stalwarts in plastic surgery. These are all pencil sketches there. And I enjoy the photography. As you go to the Tirumala temple through Alipiri, you will see some rock structures there. You take a photograph, you get closer to that, you get much closer to that, and much closer to that, you realize it's nothing but Garuda formation. Formation of Garuda as you go down from the temple, from downward journey. And photography is very, stress releasing for me. You can see the ant comfortably standing on the flower. And these are the paintings in oil on canvas. These are my photographic images. And thank you very much for your time.
Thank you very much, sir. We would like to request you to come on for felicitation from TOSA. Thank you very much. With this, we call upon the session of oration is over, and I would like to request everybody to go ahead with lunch, and we'll come back to the halls, not only hall A, all the respective halls by 1:45. Yeah, it is because of the short of time. Thank you.